Our awareness of Gastro-entero-pancreatic neuroendocrine neoplasms has increased due to improvements in imaging and endoscopy, as well as updates to pathological criteria. Despite their heterogeneous nature, spanning from indolent neuroendocrine tumors to aggressive carcinomas, their prognosis is influenced by various factors including the tumor site, Ki-67 index, and disease stage. Curative surgery is feasible for only a minority of patients, while the majority require individualized, long-term systemic treatments. International guidelines recommend a multidisciplinary approach to optimize clinical outcomes. Artificial intelligence, particularly machine learning and deep learning, has emerged as a promising tool for predicting prognoses for patients with GEP-NENs. Compared to traditional statistical models such as Cox regression, AI techniques can handle high-dimensional clinical, imaging and molecular data, capturing complex, nonlinear interactions that influence survival. However, the real-world application of these techniques is limited by methodological constraints, data scarcity, and regulatory issues. This review, based on 22 AI-driven prognostic studies, divides them into three main groups. 1. Registry-based studies. These rely on large datasets like that of the Surveillance, Epidemiology and End Results Program and offer statistical power and generalizability. They have been used to predict survival, metastatic risk and recurrence in various NEN subtypes. Nonetheless, they often lack molecular or radiomic data and show limited external validation. Their retrospective design and incomplete clinical annotations further reduce their translational value. 2. Institutional cohort studies. These integrate detailed clinical, imaging and histopathologic data. Despite being more granular, these datasets tend to be small and from single centers, limiting their generalizability. Deep learning-based radiomics models applied to computed tomography, ultrasound and contrast-enhanced imaging data have demonstrated promising performance in predicting recurrence, survival and treatment response. However, concerns remain regarding their standardization, retrospective design, and limited validation. 3. Molecular and genomic studies. These employ AI models incorporating transcriptomic data and have shown potential in stratifying tumors by grade, origin, or metastatic risk. Tools like NE-TEST and gene-based classifiers have achieved high diagnostic and prognostic accuracy. However, their high cost, lack of infrastructure, and weak correlation with clinical outcomes currently restrict their use in routine clinical practice. Several barriers hinder AI's clinical adoption of GEP-NENs. In a technical sense, model performance can be undermined by small, imbalanced datasets, image heterogeneity, and a lack of multimodal integration. From an ethical perspective, privacy concerns and algorithmic bias require urgent attention, especially in underrepresented populations. Regulatory hurdles are also significant. While the FDA's predetermined change control plans and the EU AI Act provide evolving frameworks, few current AI models meet these rigorous standards. Moreover, proving their cost-effectiveness and integrating them into existing clinical workflows remain challenging. In conclusion, AI holds considerable promise in revolutionizing the prognostication and management of GEP-NENs. Future research must prioritize prospective multi-center studies incorporating radiomic, genomic, and therapeutic data. Addressing regulatory, ethical, and financial challenges will be essential to ensure equitable access and clinical utility. AI-based prognostic tools, once validated and standardized, could pave the way toward a more personalized, data-driven approach to neuroendocrine oncology.